As Dean mentioned, over kind of 2024, we focused on four kind of key areas, and I'll just give a bit of background on why we chose these areas in particular. So we reviewed the feedback we get from the public and identified any areas where maybe we don't necessarily hear a lot of feedback. And we also looked at local health and care strategies, such as the Joint Strategic Needs Assessment, abbreviated to the JSNA, the Integrated Care Board's Forward Plan, and the Health and Wellbeing Strategy for Lincolnshire. And we also wanted to make sure that individuals who are often overlooked in healthcare discussions have their voices heard. So after taking all these different factors into account, we decided to focus on menstrual health from January to March, respiratory from April to June, and neurological, which I'll pop some more information about that in the chat at the end, and then we'll close the year by looking at mental health. So why did we pick respiratory? So nationally, respiratory conditions are a significant concern due to their high prevalence and impact on those diagnosed and the healthcare system. Respiratory conditions are closely linked to deprivation, with research showing that people living in more deprived areas are more likely to suffer from conditions such as asthma, chronic obstructive pulmonary disease, known as COPD, and lung infections. And areas of Lincolnshire, such as Boston, the City of Lincoln, the East Coast, and South Holland, have wards that face high levels of deprivation, especially in comparison to the national average. And in Lincolnshire, we already know that asthma and COPD are leading causes of disability for both children, young people, and those aged 65 and over, and that the prevalence of these two conditions is again higher than the national average. However, data on the prevalence of other conditions such as pulmonary fibrosis, interstitial lung disease, and long COVID in Lincolnshire is more limited, as is information on people's experiences accessing care for these conditions. So we wanted to fill this knowledge gap, and to do this, we launched a survey for both service users and professionals to make sure we gathered a rounded view. So how did we gather experiences? We launched 2 surveys. They were mainly online. However, we recognised that not everybody can or feels comfortable sharing their views online, and this shouldn't be a barrier. So we distributed paper copies out and about at our outreach clinics, which occur throughout the county, and to local support groups. And these surveys could be sent back to us via our free post address. People could also share their feedback over the phone if that's how they prefer to do it, or in any way that best suits them. Both surveys covered the same areas, such as diagnosis, treatment and condition management, what works well and what could be improved. So who did we hear from? We heard from 223 service users throughout the county who shared their experiences on a range of conditions, mainly asthma and COPD, but we also heard from people who had pneumonia, interstitial lung disease, and other conditions. And 7 health and care professionals shared their experiences too. So firstly, we'd like to thank everyone who took the time to share their views and support this project work. After reviewing the data, both service users and professionals raised many of the same concerns, particularly in relation to what could be improved. Again, when reviewing the data, experiences did not appear to differ based on whether, say, the individual was a carer or whether they were neurodiverse, but there were differences based on the respiratory conditions. So, for example, those with asthma tended to rate their care more highly than those with interstitial lung disease or long COVID, and I'll explore that a bit more later on. So what did people say about getting a diagnosis? Overall, 70% were diagnosed correctly the first time, and diagnosis times varied depending on the condition. So 63% of those with asthma who responded to the survey were diagnosed within less than 3 months. However, for other conditions such as COPD and breathlessness, diagnosis times varied anywhere between within a month to over 18 months. And this was in some cases because people were initially diagnosed with another condition. So waiting times, 31% were waiting for additional tests or diagnosis, and from our data, COPD appeared to have the highest proportion of respondents waiting. However, regardless of the condition or what people were waiting for, they shared that they'd often been waiting for months, with appointments being cancelled at short notice, with little communication whilst waiting, so in some cases they didn't know if they were still on a waiting list, and there was little support on how to wait well in the meantime. Just under a quarter shared that they had been offered or received treatment other than medication, and this included pulmonary rehabilitation, breathing exercises, support groups, and in some cases mental health support. However, a really key issue that was raised in relation to this was accessing these services. So for some who couldn't drive or couldn't access public transport, they had to turn down going to these kind of additional offers because they couldn't get there. And there were also concerns that for some people they felt they were too unwell to travel as well. And this was also raised by professionals a bit later on, and I have a slide about that in a moment. So overall, the vast majority, regardless of which respiratory condition they had, took medication for their condition, but around 41% had faced challenges getting medications that worked for them. And these challenges covered issues such as medication shortages, particularly with inhalers, difficulties accessing specialist medication after being discharged from hospital, and finding medications that effectively controlled symptoms. And that was particularly an issue for people who often had multiple health conditions, and they would find that one medication would control some symptoms but make other aspects of their health worse. So it became a balancing act, trying to find those that kind of had a good effect across the board. There was considerable praise for repeat prescriptions. People really praised the ease and convenience of being able to order their medication and just go to the pharmacy and collect it when they needed it, and they knew it would be ready for them. So overall, respondents were asked to rate certain aspects of their care, such as being listened to, involved in decision making, being treated with care and concern, on a scale of very good to very poor. And for the purposes of this table, good includes those who selected either very good or good, and poor includes those who selected very poor or poor. And when looking at all the responses together, the vast majority of aspects of the care were rated as good. However, being offered different forms of treatment other than medication and communication between services was rated as poor. And communication between services particularly appeared to be an issue for those who are being treated out of county. However, when looking at the results in a bit more detail, say looking at how those with asthma rated their care compared to those with COPD or long COVID or interstitial lung disease, the statements in the boxes appeared to switch. So, for example, asthma, the statements look very much like this. Everything really tended to be good, except from, again, being offered different forms of treatment and communication were rated as poor. But say for interstitial lung disease, many of the good statements unfortunately moved over to the poor column. However, we were unable to tell if these differences were due to chance or they were statistically significant. And I'm happy to go over that in a bit more detail if anybody would like some more information on that. So we also asked people what works well, and for those who have regular monitoring and reviews, either every 6 months or every year, they really valued these as a great opportunity to talk to a professional about how their symptoms were, how their medication was working, and any kind of tweaks that could be made to improve their quality of life. There was also considerable praise for specialist care once people could access it, and that included asthma and COPD nurses, physiotherapists, and community rehabilitation support. And there's some quotes on the next slide that show how much people appreciated that support. Again, praise for repeat prescriptions and GPs. However, unfortunately, this was not a universal experience. Some people felt that care from their GP is certain things that could be improved. So these quotes, I think, really highlight kind of what works well and what people really did praise. So being listened to and valuing their opinion, the idea of having continuing support, and that supporting the community prevented someone from needing to go back into hospital. So what could be improved? Both, again, service users and professionals highlighted many of the same areas needing improvement, and the first being reducing the inequality in the availability of services. So both in terms of what, say, is available in the east of the county compared to the north and the south, and what different conditions are offered. Again, a call for more localised support with respiratory specialists and local support groups with those with living or lived experience. It was also felt that there was a need to manage conditions more holistically and to offer more information about alternative therapies to support the use of medication. Again, these are some quotes from service users that highlight what needed improving. and really a big focus on the idea for more local support and holistic support. So somebody said it's an hour and a half or 2 hour journey to a regional clinic in Nottingham, and I find the journey very difficult. And rather than just medication, guidance as the condition gets worse, what are the stages and any steps I could be taking and additional treatments available, etc. Also, people felt there was a need to reduce waiting times for specialist support and to provide help on how to wait well. Again, communication between services, especially those out of county, was highlighted as a concern. Increased staffing and free prescriptions for asthma. Again, this quote here saying, free prescriptions for asthma, like people with diabetes get asthma, can kill without medication just as easily. Professionals highlighted some specific gaps and areas where they felt care needed improving. They echo kind of the sentiment around the need for more localised support and holistic support, but they also highlighted gaps in, say, non-invasive ventilation and that people cannot get to hospital appointments, and the lack of specialist care for interstitial lung disease in the county. Someone saying, interstitial lung disease patients have to travel to Nottingham or Papworth for specialist care and don't have any support from the nursing team in Lincolnshire unless they need oxygen. And this situation can change quickly. People become disabled and die. So what are our next steps? So thank you all for listening today, and we'll presented this to you. We will also produce a draft report and we'll share it with various parties in the county, such as the ICB, Public Health, local universities and the voluntary and community sector for their comments. And the findings will support the ICB's review of respiratory services. And this is just a bit more of the breakdown on who we heard from. So 16 people were veterans, 2 worked in farming and agriculture, 25 worked in health and social care, 23 were carers, 9 shared that they belonged to the LGBTQ+ community, 154 had long-term health conditions, 10 considered themselves to be neurodiverse, and 57 had a disability. I would like to acknowledge that the experiences shared with us may not be fully representative of all service users who have accessed care for their respiratory health and all professionals working to support those with these conditions. We do, however, believe that all individuals' experiences are very important and where possible should be reflected on. And the strength of the data is that many common themes persisted throughout the responses from service users and professionals. So thank you very much for listening. I'll now open it up to questions and also kind of what are your thoughts on our findings. So thank you.